Now, Chapter 7 talks about the skeletal system. So in the lecture portion, we are going to be discussing the breakdown of the skeleton and the different kinds of bones, how bones are made, while in the lab portion, you'll be learning the names of the bones. Okay, so the names of the bones might not be on these slides, but you are responsible for them and you will learn them during lab. So this is a review of what is covered in lecture. A little introduction that bones are organs of the skeletal system. Okay, so each single bone is an individual organ. So the femur, for example, which is a bone in the lower limb, is considered an organ. Okay, so you want to think of individual bones as individual organs. And each bone has a lot of different tissue in it. So there is bony tissue, there's cartilage, there's connective tissue, we've got blood vessels and nerves. And bones, although we kind of think of bones as like these, very solid, not living tissue, that is not true. Okay, bones are actually alive. The cells that are found in bones, the mature cells, are known as osteocytes. And bones in general have different functions. So bones are supportive and they protect the underlying tissue. So for example, the skull protects the underlying brain tissue. It also provides points of attachments for muscles, and that's how we get to move our joints. Bones are also storage for different things. So we are able to store calcium and phosphate, and other inorganic salts. And bone tissue is also where we make our blood cells. So RBCs, white blood cells, and platelets, all of those are being made within the red bone marrow of our bones. Now we can break down the skeletal system into, categorize the bones according to their size and according to their shape. But they do have the similar structures, similar development, and similar function. So we'll take a look at the classification of bone by shape. So that we've got 4 different types of bones. According to their shape, we've got long bones, short ones, flat bones, and irregular bones. For long bones, well, those are long and narrow, and then they have these expanded ends. These ends are going to articulate or make a joint with other bones. So you'll find that these ends are covered with a cartilage, and that cartilage is known as an articular cartilage. Articular is just a fancy term for joint. So that means that these pieces of cartilage are going to be parts of joints. Now a short bone like this one, they usually look like cubes, and they include a sesamoid bones. Sesamoid bones like this bone right here is a bone that is totally embedded within a tendon or a muscle. For example, this bone right here, this is the kneecap, which is scientifically known as the patella. It's found right here in front of the knee. And the patella is embedded within the tendon of the quadriceps muscle, which is the muscle of the front of the thigh. Flat bones get the name because obviously the bones are flat, and that would be, for example, the skull, also the sternum, the scapula, which are the shoulder blades, pelvic bones, ribs, all those are examples of flat bones. Now, last but not least are these irregular bones, and these bones just have very different shapes, and they are usually connected to similar bones. So this is the bone of the back, so one of the vertebrae, and we've got tons of those vertebrae, and they all connect together. Now for the different parts of a long bone, it has this long shaft known as the diaphyses, and then the 2 ends known as the epiphyses. This right here is the femur, which is the long bone of the thigh. So this epiphysis will be connected to the hip bone to become, to the pelvic bone to become the hip joint. While this epiphysis down here will articulate with the tibia, which is one of the bones of the lower part of the leg, in order to become the knee joint. So this one is known as your proximal epiphysis because it's closer to the trunk, while this is the distal epiphysis because it's further away from the trunk. Now in the middle, between the long shaft, between the diaphysis and the epiphysis, there is a middle portion right here, and that mid portion is known as the metaphysis. Right here, this is all made out of bone, but the metaphysis used to be what is known as the epiphyseal cartilage, or the growth line. This is where bone is going to grow so that we can get taller, and at certain ages, that cartilage completely ossifies and becomes what is known as the metaphysis. On the outside, bone is covered by connective tissue, kind of like wallpaper, and that is known as the periosteum. So peri means around, osteum means bone. And then the bone you'll find is made out of two different kinds of bone. There is this compact or cortical bone, so towards the cortex or towards the shell. And that again is compact or cortical bone, and it usually makes most of the diaphysis, while the epiphyses are usually made out of spongy bone. Another name for spongy bone is cancellous bone. In the middle, there is a cavity, and that cavity is known as the medullary cavity. It is full of blood vessels and fat. The fat in the middle is known as yellow bone marrow. In our spongy bone, we've got all of these spaces, and these spaces will be full of red bone marrow, where our blood cells are being made. The medullary cavity is lined by wallpaper on the inside, and that wallpaper is known as endosteum. Endo means inside, and osteum means bone. Now for the microscopic structure of bone, the mature bone cells are known as osteocytes. So cyte means cell and osteo means bone. And osteocytes are found within chambers known as lacunae. So what happens is that these little tiny osteocytes are surrounded by connective tissue, and that connective tissue is made out of collagen and lots of calcium and other inorganic salts. Because of the calcium and collagen are very strong and can kind of suffocate the osteocyte. So the osteocytes technically protect themselves by housing themselves in these little spaces that we've termed as lacunae. And these osteocytes have to connect together in order to, exchange like oxygen and get rid of waste products and so on. And these little tunnels are known as the canaliculi. So again, you've got osteocytes housed in lacunae and surrounded by collagen and inorganic salts. The collagen gives the bone the resilience to withhold pressure and to withhold our weights, while the inorganic salts gives strength to the bone. Now, the little differences between compact and spongy bone. Compact, again, is cortical. It's on the outside. And on the inside, you can find the spongy bone. The compact bone, when you look at it under a microscope, it is made out of these little osteons, and we'll talk about the structure of the osteons in a second. It is the compact bone, they're stronger and more solid. They help in weight bearing, and they resist compression. But if all of our bones were this solid, the skeletal system would be extremely heavy. So in the middle, we tend to have that little spongy bone. And you can see here, spongy bone as opposed to the compact bone towards the surface. This is the skull, and you can see compact bone on either sides with spongy bone in the middle. Spongy bone are made, it is not made out of osteons. Okay, so osteons are only found in your compact bone. Spongy bone, on the other hand, are made out of these trabeculations, so they are called trabeculae. It is a little bit more flexible. They do have these spaces, and these spaces are full of red bone marrow. As we age, though, the red bone marrow tends to get replaced with fat. Okay, and that is why, you know, the amount of blood cells as we age tends to change. Now let's take a closer look at the osteon and what it looks like. So right here is a long bone. This is, again, your spongy bone, and that's your compact bone. And in the middle, you have the medullary cavity with the blood vessels. And this is what you're seeing. So this is kind of like a slice off of the bone. Here in the middle, again, is your medullary cavity with an artery, a vein, and that yellow nerve. And then you see here the spongy bone followed by the compact bone. Now, the compact bone still needs oxygen. Okay, remember, bone is a living tissue, so these osteocytes need oxygen. How is it that oxygen that is found in the blood right here, how is it that it will reach all of these cells? Well, blood vessels are going to invade the compact bone through these little tunnels, and these tunnels are known as perforating canals. And then the blood vessels will go vertically up and down in order to distribute oxygen to all of the osteocytes. And these, the vertical canals are known as the central canals. Now, each central canal has an artery, a vein, and a nerve. The osteocytes will arrange themselves around that central canal. So kind of like a tree trunk where you have a central canal in the middle with an artery, nerve, and a vein, surrounded by layers, concentric layers of osteocytes. These concentric layers are known as lamella. So the lamella are the layers of the osteocytes surrounded by the matrix, and all of those are around your central canal. So again, around the source of oxygen. Now, how is it that our bones grow and develop? Okay, the parts of the skeletal system actually start to develop in the very first few weeks of prenatal life. Okay, but we keep on growing and developing our bones way into adulthood. So you will see, you know, that some bones don't really complete the whole development process until maybe in the mid-20s. There are two different ways that we can grow bones, depending on the kind of bone. So flat bones start off as membranes, and we call those intramembranous bones, while long bones start off as cartilage, and we call those endochondral bones. Okay, so you see here, these are images of bone development in a fetus at week 14. Again, bones can either start off as a membrane, and that membrane will ossify. So ossify means to change into a bone. Will ossify in a process known as intramembranous ossification and end up making a flat bone. So those again could end up being a skull, clavicles, ribs, sternum, scapula, pelvic bones. All of those are examples of flat bones. Now, this connective tissue is made out of a primitive connective tissue known as mesenchymal stem cell. Okay, that word is found maybe in the next slide. Mesenchymal stem cell is basically a stem cell that can change into any kind of connective tissue. But because the signals in this area will be telling the stem cell to change into a bone, that mesenchymal stem cell will do exactly that, will change into bone cells. And we'll talk about the process in a little bit. Now, on the other hand, endochondral ossification, which are basically your long bones and, the rest of the skeleton, start off as hyaline cartilage, okay, which is basically kind of like a model of the bone. It pretty much looks like the bone, but it's not bony yet. It's made out of cartilage, and you want to know that it is hyaline cartilage in particular. So let's talk about the steps of intramembranous ossification. So remember again, we started off as a mesenchymal stem cell, that little flat membrane made out of mesenchymal stem cells. Okay, these are very primitive cells and they have the ability to change into any kind of connective tissue cells. But because all of the messages and the signals in that area will tell them to change into bone, that's what they will do. They will develop first into osteoblasts. Know that any term that has the word blast at the end means that it will mature, it will change and grow up to become another cell. So osteoblast will change into bone when that cell grows up. Okay? In order for that cell to grow up, it has to surround itself with collagen and start depositing collagen and depositing the inorganic salts. When it does that, the osteoblast has right now at that point has pretty much trapped itself in collagen and in calcium, and has now changed into an osteocyte. So the mature grown-up cell is an osteocyte, and it is now housed in the lacunae. The mesenchyme on the outside is going to make the periosteum. So let's take a look at this kind of like in an image format. So right here are your mesenchymal stem cells. Okay, again, the signals coming, certain local factors are telling these cells to change into bone. And where the process starts is known as the ossification center. These mesenchymal stem cells will change into osteoblasts. So you see them now changing into osteoblasts. They will start depositing collagen fibers and inorganic salts. When they do that, they are now called osteocytes. You can see them now housed in the lacunae. While the mesenchymal cells on the sides, are going to develop into the periosteum. And now you can see the bone in the middle with the periosteum surrounding it. Endochondral ossification is different. We start off as hyaline cartilage. These are going to develop into the longer bones and pretty much the rest of the bones. The process is kind of the same. So we start off with hyaline cartilage cells known as chondrocytes. These chondrocytes are going to get bigger and bigger and bigger until they pretty much get too big and they just die. The chondrocytes will die, and the body thinks that there is something going on, something wrong happening in the area. So lots of blood vessels are going to invade the area to take care of these dying chondrocytes. The blood will bring in osteoblasts into the area. The osteoblasts again surround themselves with collagen and inorganic salts, and they change into these mature osteocytes. So look at it again in kind of like this image format. So you can see here that the cartilaginous model kind of looks like, takes more or less the shape of the long bone that it'll end up being. And you can see here that the ossification process will start right here in the middle. So you have a primary center of ossification that happens in the middle, where you can see here these chondrocytes that are growing and dying. And when they start dying, they become calcified. The blood vessels will come in and bringing in osteoblasts to kind of take care of these dying cells. Now the osteoblasts will start to surround themselves with collagen and inorganic salts, and hence now we have changed that pad of cartilage into mature bone. The process will also happen in the epiphyses. So you see them starting over here, and these are known as the secondary centers of ossification. So the primary center is in the middle, and that will give you the diaphyses, while the secondary centers of ossification are found in the epiphyses. And this will keep on going until most of the cartilage, notice I said most, not all, most of the cartilage is ossified. The bone will, or this whole process will spare some of the cartilage. So the cartilage that is on the outside over here will become articular cartilage. So this will become part of the hip bone, while we'll keep part of the cartilage on the other end to become articular cartilage as well and become part of the knee joint. Okay, so provided that this is a femur. Okay, we also are going to spare these epiphyseal plates, which are the growth plates, so that, the baby can grow taller. And this is how they get taller, by these epiphyseal plates. You can see here now, they're getting taller, the epiphyseal lines kind of, shrinking, and they will become totally ossified and change into that metaphysis that we saw at the very beginning, which is now total loss or total ossification, complete ossification of the epiphyseal plates. And here you can see kind of like side by side comparison between intramembranous ossification and endochondral ossification. And I am going to let you guys kind of go over it on your own and come back to me with any questions about it if you have any. Now, how is it that the epiphyseal plate has the ability to grow that bone taller? Okay, so the epiphyseal plate is made out of 4 different layers. And the layers are the zone of resting cartilage, zone of proliferating cartilage, zone of hypertrophic cartilage, and zone of calcified cartilage. Oops. And to remember it, if you take the first letters, we can get a mnemonic known as real people have career options. O stands for ossification. And it goes, the layers or the sequence of the layers goes from epiphyses towards the diaphyses. So I will tell you what I mean by that. But if you look here at this bone right here, this kind of looks like the humerus. So the shoulder would be up here and the elbow would be at the distal part. This is the epiphyseal plate. Okay, so here is your first zone, that is the zone of resting cartilage. So the zone of resting cartilage is at the top, and the zone of calcified cartilage and ossification would be towards the diaphyses. And you want to know the layers in order, and you want to make sure that you know which order you're looking at. So if you are asked about the order of these zones from top to bottom, so from the epiphyses towards the diaphyses, then this is the correct order. If you're asked about them in the opposite sequence, so you want to make sure you're familiar with what sequence we are talking about. When we do this discussion, I will be going from the epiphyses towards the diaphyses. Okay, because that's how the growth occurs. Okay, this part up here is known as the zone of resting cartilage, and it's pretty much just chondrocytes, and it anchors this diaphysis, the shaft of the bone, to the epiphyses on top. Okay, so you can see here the zone of resting cartilage again are chondrocytes with, and all that they're doing is anchoring the shaft of the uterus of the bone down here to the epiphyses on top. Your second zone is the zone of proliferating cartilage, where these chondrocytes are growing. They are going to grow massively. So you can see the third zone is the zone of hypertrophic cartilage. Hypertrophic means huge cells. And remember that these cells are going to keep on growing until they die and become calcified. And that is your fourth zone, which is the zone of calcified cartilage. Now, osteoblasts will come in. These osteoblasts surround themselves with collagen and inorganic salts, hence growing up into osteocytes and giving you now that last zone of ossification or ossified bone. Okay, so adding to the length of the diaphyses. This looks exactly the same as endochondral ossification because it actually is. Okay, so that whole process, how we grow, is the exact same way of endochondral ossification because we are doing the same process where hyaline cartilage is changing into bone. Now we've got, we kind of talked a lot about growing bones and osteocytes and osteoblasts. And we said that osteoblasts are kind of like baby bone cells, and they have to mature and grow up to become osteocytes. We did not discuss osteoclasts, though. Osteoclasts get rid of bone tissue. So remember, bone tissue is a living thing. We are always getting rid of old, worn out bone tissue and replacing it with fresh, new bone tissue. So in order to get rid of your old osteocytes, that is the function of osteoclasts. Okay, osteoclast performs a process known as resorption. It will break down the collagen and break down the calcium and all of those inorganic salts and release these salts into the bloodstream. Okay, while osteoblasts do the opposite. Osteoblasts will deposit the inorganic calcium or the inorganic salts. It will take these salts from the bloodstream and deposit it onto the bone. And that process is known as deposition. So these two cells do the opposite of each other. Osteoclasts performs resorption, while osteoblasts perform deposition of bone. Okay. And again, this process keeps on occurring throughout our life. It's not, and where there's a balance between the action of osteoblasts and osteoclasts. It's not until actually pretty early in age, like in early 30s, even sometimes in some textbooks, they'll tell you in the late 20s, where the breakdown by osteoclasts tends to be faster than the buildup by osteoblasts. This is definitely true in women, especially after menopause, where there is a lot of resorption of bone and not as much deposition of new bone tissue. And that leads to osteoporosis if it is not taken care of. Here, this is a table that shows the different, years of when things ossify in the skeleton. It is not something you will be asked about, but I thought it is kind of interesting to kind of, know these different numbers. So, usually the majority of the class kind of lies in this category, or in this category right here. So if you're a 23-year-old female or a 25-year-old male, then at that point, pretty much all of the bones have been ossified. So this would actually be a very good time to take a break and then stretch and come back. So welcome back, folks. Now we will be talking about homeostasis of bone tissue. Wait, so we actually have to balance our bone tissue. Yes, we do. Okay, we have to have that balance between removal of our old bone cells through bone resorption that is done by osteoclasts. We want to balance that with bone deposition, which is the formation of new bone cells, and that is the action of your osteoblasts. Annually, we replace about 10 to 20% of our skeleton. Again, as we age, bone resorption tends to be more than bone deposition, and this is especially true in menopausal females, leading to, if it's not taken care of, that can lead to osteoporosis. So what are the factors that affect our bone growth and bone development? Well, we want to talk about 3 vitamins, 4 hormones, and exercise. Okay, so physical stress means exercise. We are not saying that you want to be emotionally stressed out to grow your bone. We're talking about physical stress. And that physical stress or exercise stimulates bone growth. Okay, so we'll talk about the 3 vitamins, vitamin D, A, and C. We all know that vitamin D is really important for calcium absorption. Deficiency in vitamin D in kids can lead to a disease known as rickets, while vitamin D deficiency in adults is known as osteomalacia, where pretty much there's not enough calcium and the bones are very, remember calcium adds strength to the bones? Well, without that calcium, the bones are very brittle. Vitamin A is important for both the activity of osteoblasts and osteoclasts. So if a deficiency in vitamin A can lead to retardation of bone development. Vitamin C is important for collagen synthesis, which is nice. C and collagen starts with the C, so that helps me remember. And remember, collagen is what, we have to deposit lots of collagen in order to have strong bones. Well, if we lose that collagen or deficiency in vitamin C, can lead to these very fragile bones. Now to the hormones. Well, growth hormone, it kind of implies through the name that it will stimulate the growth of our bones, which is true. Growth hormone insufficiency, so not enough growth hormone, can lead to pituitary dwarfism. And we will learn when we talk about the endocrine system that growth hormone is secreted by the anterior pituitary, which is a gland in the brain. And so insufficiency of growth hormone, is known as pituitary dwarfism. The release of too much growth hormone, well, that depends on when that starts in life. So if it starts in childhood, where the growth plates and the epiphyseal plates are still intact, that can lead to gigantism, where the individual gets very tall. But if growth hormone excess occurs after, in adulthood, where the epiphyseal plates are now all ossified, well, bones can no longer grow in length, but they start growing in width. And that leads to a condition known as acromegaly. The next hormone that affects bone growth is thyroid hormone, and that comes out of a gland in the neck known as the thyroid gland. Okay, thyroid hormone is important for osteoblastic activity. The PTH or parathyroid hormone is a hormone that comes out of a gland known as a parathyroid gland, and we will learn in the endocrine system that we have 4 of those, and those are found behind or actually embedded within the thyroid tissue. Parathyroid hormone stimulates osteoclasts, so it actually helps in breakdown of bone. So you definitely want to keep that in mind. Okay, so when osteoclasts are stimulated by PTH and bone starts to break down, releasing calcium from bone, that extra calcium will go to the bloodstream. Now, the next hormone to talk about are sex hormones, so estrogen or testosterone, and both of those promote bone formation. So you know that during puberty, that growth spurt that happens is because of the increase in these sex hormones. It will stimulate the growth of bones and then lead to the completion of ossification of these epiphyseal plates. And we kind of already touched on physical stress. So we'll talk a little bit, kind of like, let's tie this to different clinical things. So fractures, which is a very common thing to occur. There are simple or closed fractures where the skin is not injured. The skin or the mucous membrane are intact. A compound or an open fracture, that's when the bone is exposed to the outside world, either through a broken skin or broken mucous membrane. These are types of fractures. The first one to talk about over here is known as a green stick fracture, and that is an incomplete fracture, and it usually happens in kids. You can think about it kind of like taking a green stick off of a tree, the little branch that did not completely harden, and it's still green, and you try to break it. Okay, it usually does not break totally, so it's an incomplete fracture. And that's what a green stick fracture is. A fissure, on the other hand, is an incomplete longitudinal break in the bone. A comminuted fracture is where there are tiny pieces of bone in the middle. So you have, the two major pieces, but then you've got these little fragments of bone as well. These comminuted fractures usually need surgical intervention in order to kind of piece these bones together. A transverse fracture, that occurs at a right angle to the axis of the bone. So what on earth does that mean? It means that this right here is the axis of the bone, up and down. Okay, the fracture happened at a perpendicular angle, at a right angle to the axis of the bone. Okay, or an easier way of knowing this is that it is a transverse, it went transversely through the bone. An oblique fracture would be, again, if we're looking at the axis of this bone, the break was not perpendicular, was not at a right angle, it was at any other angle besides the right angle. So it's an oblique, it is sideways fracture. A spiral fracture is when there is excessive twisting of the bone. And this is very common in soccer players where, they try to get the ball and they kind of slide and twist their feet. And this is how these spiral fractures usually happen. Now, how does a fracture repair? Okay, remember we talked about the repair of skin. It is pretty much the exact same thing. The body really doesn't have different ways of repairing itself. Okay, we're always going to start off with a blood clot. We'll bring in white blood cells to get rid of germs and cellular debris. We'll bring in fibroblasts to start the healing process. And then we will make our osteocytes. Okay, so obviously osteocytes are unique in this scenario. Okay, so let's talk about the hematoma, which is our blood clot. Okay, to stop the bleeding. Now, when that happens, bone doesn't really change or repair itself by making bone right away. It'll make a cartilaginous callus. And that is why we have to put a cast on fractures. Okay, so that because we start off by mating a cartilage first. And then the cartilage ossifies to bone. So if this cartilage is misplaced, or if it is moved all the time, then the bone is not going to unite, is not going to heal properly. And that sometimes actually does happen. And then, we'd have to go surgically refracture the bone and reposition it and then cast it so that the healing occurs correctly. So again, we start off as a cartilaginous callus. The phagocytes, which are the white blood cells, are going to come in, remove cellular debris, attack any germs trying to come in. Fibroblasts will come in and invade the area. Okay, in this case, they're more specifically fibrocartilage cells come in. Then the cartilaginous callus is going to change into a bony callus. So osteoblasts invade the area and they start depositing again your collagen and inorganic salts, changing into osteocytes. And then because you can see here that the bony callus kind of looks irregular, the bone will remodel itself. Okay, so osteoblasts and osteoclasts will come in and remove the osteoclasts, I apologize. The osteoclasts will come in and remove all of the excess bone tissue in order to make it as smooth as possible. Now, what are the different functions of bones? And we already touched up on this kind of, when we talked in the beginning. They do provide shape to the body, okay? They provide support to different body structures and protection. They help body movement because of the presence of joints. They have red bone marrow that will produce our blood cells, and it stores inorganic salt. So we're going to get into details of some of these. So in support, protection, and movement, for example, as we said, the bones are going to support our body weight, okay, especially the bones of the lower limb and the vertebral column. The skull bones, for example, protect our brain, ears, and eyes. The rib cage protects the lungs and the heart. The pelvic girdle will protect the reproductive organs and the lower abdominal organs like the urinary bladder. And our bones and muscle combined together will provide our movement. Now, the formation of blood cells is known as hematopoiesis. Poiesis means to synthesize, to make something. Hemato means blood. So we are making blood cells. So again, the process of blood cell formation is known as hematopoiesis. It occurs in the red bone marrow, and we know now that red bone marrow is found in our spongy bone. The red bone marrows will make red blood cells, white blood cells, and platelets. As we age, red bone marrow gets replaced by fat and becomes known as yellow bone marrow and will not be able to produce as many blood cells as it used to. What about the storage of inorganic salts? So which inorganic salts do we keep on talking about? Obviously, the most important is calcium. Okay, calcium is deposited or stored in bone in the form of calcium phosphate, also known as hydroxyapatite. Other salts that are stored in our bones are magnesium, sodium, potassium, and carbonate. As we age, we tend to lose some of the bone. So loss of bone mineralization, which are these minerals, is a condition known as osteoporosis. And I would like you to pause and ask yourself, would the increased activity of osteoclasts or osteoblasts lead to loss of bone mineralization? So if you answered osteoclasts, you are correct. Okay, so osteoclasts breaks down the bone tissue, releasing these inorganic salts into the bloodstream. And the hyperactivity or the imbalance where osteoclasts outnumber osteoblasts as we age will lead eventually to osteoporosis. Now, know that calcium has two places in the body, okay, either in the bloodstream circulating or stored in bone. Okay, and because calcium is extremely important in muscle contraction, it's important in the conduction of electricity on our nerves. there are two hormones that are responsible for regulating the level of blood calcium in our body. And those two hormones by name are parathyroid hormone, or PTH, and calcitonin. So let us take a look at what happens when blood calcium levels change. So if the level of blood calcium levels is too high, okay, that is going to stimulate the receptors of the thyroid gland to release calcitonin. Calcitonin will stimulate osteoblasts, and osteoblasts, if you guys remember, will deposit bone. Will take that calcium from the blood and deposit it onto the bone tissue. That means that calcitonin will eventually bring the calcium blood levels back to normal. I like to think that calcitonin gets the name from its function. So calcitonin tones down the calcium levels of blood. And it does so by the activation of osteoblasts. Your other scenario is that if calcium levels are too low, that stimulus of hypocalcemia, or low blood calcium levels, will stimulate the receptors of the parathyroid glands to make a hormone known as PTH, or parathyroid hormone. That in turn will stimulate the osteoclasts to break down the bone tissue, releasing the calcium into the bloodstream, bringing the blood calciums up back to normal. So again, your calcitonin activates osteoblasts, while parathyroid hormones activate osteoclasts. Now, how is it that we can prevent fragility fractures? First off, what are fragility fractures? Fragility fractures happen in bone that has very low density. So, for example, in osteoporotic patients, and can happen due to very minor trauma. So let's say, a fall that would normally not break a bone, but because these individuals have osteoporosis, it actually did break their bone, okay? It did lead to a fracture. So that's what a fragility fracture means. It is a fracture in fragile bones. So as we said, that bone remodeling occurs throughout our life. It's not until as we age, where osteoclasts outnumber our osteoblasts. So osteoclasts are always removing more bone tissue than the deposition happening by the osteoblasts. That leads to osteopenia, which is bone loss that can progress to osteoporosis. And you can see here what osteoporotic tissue would look like. So any minor trauma can actually lead to the fracture of this bone. And it is estimated that about 50% of people, 50 or better, actually do have some sort of bone loss. Okay, and again, it's more common in postmenopausal women due to the hormonal changes. So how can we prevent fragility fractures? Well, you want to prevent osteopenia and osteoporosis. And you do that by getting at least 30 minutes of exercise every day, and that includes weight-bearing exercises. Weight-bearing exercise does not necessarily mean that they carry weights. It means, for example, walking, jogging, an exercise that you are using gravity, okay? You are not eliminating the factor of gravity. For example, swimming is not considered a weight-bearing exercise because being in that water kind of eliminates the effect of gravity. So you want weight-bearing exercises. These are the best for bone health. You want to tell your patients to get enough calcium and vitamin D, which is really an issue, especially in cold areas, for example, in Michigan, and to not smoke. Okay, so one of the many reasons to not smoke would be to prevent osteoporosis. What are the lifespan changes that happen to our skeletal system? Well, we tend to shrink, Okay, and that really happens at a surprisingly early age. Calcium levels start to fall. Bone starts to become brittle and we are more prone to fractures. As I mentioned, osteoclasts start to outnumber our blasts. And we would expect spongy bones would get weaker before our compact bones because they are already, not as solid as compact bones are. Bone loss tends to happen quicker after menopause in women, where hip fractures and other fractures become common. Vertebral compression fractures are also common, where backbones tend to break. So I'm going to go over a couple of features where, about the skeletal system, where kind of like lecture tends to overlap with lab here. So skeletal organization, our adult skeleton is about 206 bones in total, okay? Some might have extra bones here and there, while others do not. But on average, we all have about 206. Example of some extra bones that some might have. So for example, this bone right here, that is known as a sutural bone, which is a bone, most individuals have these two parietal bones and an occipital bone, while some have a little tiny bone connecting all three of these together, and that is known as a sutural or a Wormian bone. Okay, we've got these little bones embedded in tendons, like small sesamoid bones, and those are to eliminate and reduce friction. Okay, so the patella is a big sesamoid bone that we all have, but there are other sesamoid bones that some of us have and some of us do not. But again, on average, the majority of us will have 206 bones. So how are these 206 organized? Well, we've got this green axial skeleton. Those are about 80 bones, and those include the bones of the skull and the middle ear, the hyoid bone, which is a bone in the middle of the neck, the thoracic cage, and the vertebral column. The appendicular bones are hanging from our axial skeleton, and those are 126 bones. Those include your pectoral girdle, which are the shoulder bones, and the bones of the upper limbs. It also includes the pelvic girdle, which are the pelvic bones, and also the bones of the lower limbs. If you look at an infantile skull, so remember most of the skull bones are flat bones, okay, and they are going to eventually all ossify, but there are where they are ossifying or where they have not ossified yet, we still have these little membranes. Those are the soft spots on baby heads, and those are known as fontanelles. So fontanelle literally means window, okay, so there's pretty much nothing between you and the brain except for that little fontanelle, little membrane. There is one in the front and one at the back. So there's an anterior fontanelle that usually closes up, anywhere between 9 months and 2 years. And then there is a posterior fontanelle in the back, and that usually closes up or completely ossifies at the age of about 2 months. The anterior fontanelle is between the two frontal and two parietal bones, while the posterior fontanelle is between the two parietal and the occipital bone in the back. For the vertebral column, or the backbone, we've got these different curves. Okay, some of them are known as primary curves, some are known as secondary. So let's break down the different areas of the column. So we have a cervical in the neck. Okay, those are 7 vertebrae. We've got 12 in the thoracic or in the chest area, 5 in the lumbar area, and then we have 5 in the sacral area, but they're all fused together to make this bigger sacral joint, sacrum bone. And then the coccygeal bone is made out of 3 to 5 fused bones. So I know your textbook says 4, but it's actually somewhere between 3 and 5. Some have 3 fused, Some have 5 fused, so the textbook kind of chose the average. Now for the curvatures, as in utero, we are all curved in that fetal position. Okay, so we're kind of curved towards the front. So the curves that we keep that are the same as in utero, those are known as your primary curves. And those include the thoracic and the sacral curvature. Know that this is the front and this is the back. Okay, you can see the spines, and these are the spines that you feel on the back. If you kind of run your finger down the middle of your back, you are feeling these spinous processes. Okay, the curvatures, again, the primary ones are the thoracic and the sacral. The secondary ones, we develop those as we learn the ability to maintain posture, to carry our heads, and to carry our weights. So the curve changes in the opposite direction. So the secondary curves that we develop as we grow are the cervical curvature and the lumbar curvature. Now, what are some disorders of the vertebral column? One of them is, these are common, but a very common one is a herniated or a ruptured disc. In between the backbones, we have intervertebral discs. Sometimes these discs tend to bulge out and compress the nerves that are surrounding them. That can lead to pain and numbness and even loss of muscle function. Now, kyphosis, that is an exaggerated thoracic curvature. So if you've seen, for example, the Hunchback of Notre Dame, for instance, okay, that is an exaggerated thoracic curvature, and we call that kyphosis. Okay, we can scoliosis, for example, which is actually more common than we think. Scoliosis is an abnormal lateral curvature of the spine. So where the two shoulders are not at the same level, or the two hips are not at the same level. Okay, and that can lead, in its severe form, can lead to the compression of the internal organs. Lordosis is an exaggeration of the lumbar curvature, so a sway back, and that usually happens with, for example, towards the end of pregnancy, where there is an exaggerated lumbar curvature in order to maintain balance. A compression fracture is when a vertebral body fractures and compresses, the nerves that are surrounding it. Okay, that can happen either due to osteoporosis or can happen due to metastatic cancer, for instance. The thoracic cage includes bones of the ribs, the thoracic vertebrae, the sternum, and the costal cartilages that attach these ribs to the sternum. Okay, it supports your shoulders, which are your pectoral girdles and your upper limbs, and it protects the viscera, so it protects the lungs and the heart, and it does have a role in breathing. So if you take a look at the ribs, okay, we have 12 pairs of ribs, so 12 on each side. We have the first 7, or the 7 from top to bottom, the first 7, those are known as true ribs, okay, where each rib is connected to the sternum with its own cartilage, and that cartilage is known as a costal cartilage. The remaining 5 are known as false ribs, okay. The first 3 of these false ribs, as you see here, their cartilages unite and then can connect at one point to the sternum, and those are known as the vertebrochondral ribs. The last 2 ribs don't even have costal cartilages at all. They do not connect to the manubrium, and they are floating in the back, and we call those floating ribs. And these ribs can rupture and can lead to damage of the surrounding structures, for example, damage of the spleen. Some individuals actually have an extra rib, okay? So You know, there is variation, but the vast majority of us have 12 pairs of ribs. Now that is the end of this lecture. Remember that you want to be familiar with the different bony parts, and you will learn those in the lab portion of the course.